I chose this topic just to go over a couple common sports type of injuries that one may encounter on a day-to-day practice, even if you don't only do hand. These are a couple injuries that I chose. So hopefully if you haven't seen these, if you do, it'll make it hopefully straightforward for you guys. So TFCC injuries, you learned about how to examine the TFCC. It's a complex structure. Again, we could talk about for hours about the anatomy and what it does. And if an MRI report comes back abnormal, what does it mean? Just like if you learned about neck and back problems, just because an MRI report is abnormal doesn't mean that the patient needs a fix for it. So again, you have to correlate clinical exam, history, and other findings to confirm what's going on. But here's kind of a structure of what it is. It's pretty interesting. But again, we have degenerative type problems. We have acute injury type problems. So if someone just has ulnar side at wrist pain and they never had an injury, then their tear or whatever, I don't know why radiologists say the word tear, in all honesty, because wear and tear, the word tear is in that, but I didn't make that up. That was Howard Routman. But TFCC evaluation, so ulnar side at wrist pain is what they'll come in complaining of. And if they had an acute injury, some sort of fall or twisting moment on their wrist, and they had pain with supination, pronation, that's kind of what ties me into that. You can have pain on the ulnar side of your wrist to your tendon, to your fovea, to where the TFCC is, or you can just have pain over the snuff box or pain somewhere completely different. So more times than not, I see a patient with an abnormal MRI finding, and they don't even have ulnar side at wrist pain, or maybe they didn't even have an injury. So you kind of have to tie everything together. You can have arthritis, you can have ECU tendon problems, are probably the most common diagnosis for ulnar side at wrist pain. So this is what it looks like on MRI. This is what it looks like when you operate on them. Again, it's not common we're doing surgery to fix these unless it's in an acute, traumatic, or setting where the distal radial ulnar joint is actually unstable, which again, all those are fairly rare. And these are different classifications of where it can tear and how it can tear, whether it's degenerative or something acute where you can consider doing a repair. So similar to the meniscus in the knee, if you have a central tear, that's not something you're going to suture or bring back. You're just going to debride because of a blood supply issue. If the tear is peripheral, then you're able to do a repair and bring it back down to the insertion at the fovea. So moving on to fingers. For those of you up north, you might call it a stove finger. For everybody else in the world, I think they say jam finger. I jam my finger. So. If you play baseball for the Rays and don't know how to slide back into first, you can dislocate your finger. You should probably play that again. It's kind of the best part of the talk, this video I just put in. Yeah, so Pham still plays left field, and I don't know, he can't slide back in. It wasn't even close, but he dislocated his finger, I think it was last year, and usually you see the trainer going out and trying to pop it back in on the field, which in basketball, I think they routinely do buddy tape and keep playing, but in baseball, they're not as tough. They sit out for a couple weeks. So radiographic evaluation, or football too. Football, they'll just do an amputation on the sidelines and then go back in. So you're gonna look at the fingers, you're gonna look at the cascade, you're gonna, now you guys know how to do a good exam. You're going to check out where they're actually sore. So just because something's black and blue doesn't mean it's sore. And PIP joints, from an evaluation standpoint, there's a lot of stuff that'll be seen in an urgent care setting or primary care setting. These are things that we like to see sooner than later in a hand surgery practice, because if it's stable, we'll get them into therapy, we'll allow them to move it. We don't immobilize finger joints, especially the PIP. DIP, yes, for mallet finger and such, but PIP, like an elbow, you want to make sure you get moving so you don't have stiffness. So you want to get good x-rays. Again, here this shows an x-ray from an unstable fracture subluxation. So these are things that you want to look at when you're evaluating your x-rays. A lot of times you'll order x-rays of the hand and it'll just show all the fingers and you can't see the dedicated lateral of the finger. So definitely you need that for a PIP injury, whether it's a dislocation or just a sprain. So clinical evaluation, again, I think you guys get that after the last talk. You want to make sure there's a concentric range of motion that's stable. So active stability, if someone has pain, you can always numb them up and test them too. Elson's test tests the central slip. That's more for a volar dislocation of the PIP joint. So dorsal PIP dislocation, this is most common. This is what you'll primarily see. Again, a simple dislocation is not associated with the fracture. So this is something you should be able to reduce and buddy tape and start active motion. For some reason it's associated with the fracture, there's other treatment options. But again, even in this patient, you reduce it. If they're seen within a couple of days or a week, we'll confirm that and allow them to get back to their motion and rehab so they don't get stiff. So these are the different types of injuries. You could just have a hyperextension, you can have a dislocation, or a fracture dislocation. So if you kind of break them down in either of these two, type 1 and type 2, they're going to be stable. They can do active range of motion. Even if there's a small little volar plate fracture, that doesn't matter. Like this, you see this x-ray here, okay? It's very small. You have to zoom in on your PAC system. This doesn't matter. This is not anything that needs surgery. They can do active range of motion. They don't need to be splinted. PIP injuries or finger injuries, the full finger splint option is not necessarily useful. If you know they have a dislocation of the PIP joint, which I'll get to in a moment, that's volar, you can splint just the PIP joint in extension because the central slip is injured. If it's just a mallet finger, you can just splint the DIP joint. So again, hyperextension injury, simple buddy tape, range of motion. Dislocation, okay, it's fairly simple and straightforward to reduce. It should reduce easy. If not, there's other things that sometimes we have to do. So this kind of shows that early range of motion, because these injuries get stiff and they hurt for 3 or 6 months. They'll always notice there's some swelling at their finger. It's not going to go away. It's just the injury. So you just educate people mainly for these injuries. So here's a fracture dislocation. These are unstable injuries. These usually require some sort of surgical intervention. So these are ones, again, it's nice to see these injuries within a couple days of injury, not 6 weeks out, because 6 weeks out, there's kind of difficult to fix. So if it's unstable, we can send them to a hand therapist. We can make a splint, and you do a dorsal blocking splint, allowing flexion because it's stable in flexion, however, preventing maximum extension, and then dial it back in over time. You can do a pin, so a pin acts like a splint. You can do that. That works for a majority of these that are very comminuted. You don't have to open the joint up. In theory, maybe you get a little less stiffness. But again, something's being done for these. Again, if you look at the x-ray in the bottom left, you see there's dorsal subluxation, or what they call the V sign. This is something we're going to do something for. In this paper, this just shows, okay, if you do just a pin and you follow patients over time, the joint looks pretty good, even though initially it didn't. You can open them up and put screws. I mean, they work okay for the right patient. You can stabilize the joint. If you're going to have them opened up and fixed, from our standpoint, we get them stable and we get them into therapy right away. This is not something we cast for a while. If you want to get fancy and you can't fix it, or in a later case, this guy came up with this idea of taking the hamate. There's cartilage on the hamate where you can take a bone graft and then place it on the base of the middle phalanx, providing a stable concentric PIP joint. Again, if you do this, you're going to send them to therapy and you're going to allow motion. So these do okay. You see someone like this that might be 6 or 8 weeks out, it gives them an option over doing a fusion. So lateral dislocations, I think a lot of people see these. Sometimes they can be fairly unstable chronically. I know some people, I know even one surgeon, an orthopedic surgeon who has this, and every time he puts on a glove, it dislocates and he just kind of pulls it back in. So I guess you can live with this. There's probably someone in the room who has this. However, if it's stable, then they're usually okay. So this is a volar dislocation. So if you see this is something that you're not going to just buddy tape and do range of motion, because the central slip or the extensor mechanism that inserts here is disrupted too. So you're going to do a closed reduction. Here's a little avulsion variant. And then you're going to splint the PIP in extension while allowing DIP active motion. So you're going to just splint the PIP only, allowing active DIP motion. I usually send them to hand therapists. All right, another video. So never slide into first base. I think they teach you that when you're like 6, but some people like Kermeyer say, look, he's examining his thumb there. So you guys know what he injured there? So his ulnar collateral. So. Looking at the history of all these mitts that people wear, this guy in the top left, this guy for the Royals, I forget his name because, I don't know, he's not a famous guy, but he came up with this idea of wearing this mitt that you see everybody wear now. So I don't know 100% if it prevents injuries. I think it does, but I think there's some in sports medicine and hand surgery literature that'll probably follow if it hasn't been already. You guys might know better than me. So hamate fractures can occur when you're batting or playing golf. This is something that you don't want to miss. Again, getting back to exam, if someone has ulnar side at wrist pain, if they're sore over the hamate, they can get hurt by batting, they can get hurt by playing golf. There's different types, different locations. Check swings potentially could occur. If they're sore over here, you don't want to miss this fracture because they can have a tendon rupture of the profundus to the small finger. So it's a very annoying injury to have. People have pain over their ulnar side of the hypothenar eminence. They can have ulnar nerve paresthesias, weakness in grip. So this is the time you would get a carpal tunnel x-ray along with the CT scan. So the CT will show it. If the fracture didn't heal with time, say a couple months, then we go in and excise this fragment so they don't have a tendon rupture. So in overview, again, history and physical exam is everything. You're going to see these injuries come into your office, I'm sure, no matter what specialty you do. Why? Because hand injuries are very common. If you see an injury to the finger, like we talked about for PIPs or even elbows, I know I didn't talk about elbows, but a referral sooner than later is probably beneficial to the patient. A lot of times it's education, get back to moving and get back to your life, get back to your sport. When there's times where they need something, we can intervene and get them back right on track as well. So thank you.